oncology nurses in the United States. But what I learned yesterday was something very distinct about the need and the role of oncology nurses focused solely on lung cancer. Glenda, you're going to talk about that role, nurses in lung cancer, not only patient support, but in research, and why. Why does lung cancer, I know what the doctors told me, but why does lung cancer really necessitate this distinct effort by nurses?
For those that don't know, on Sunday here at the conference, we actually launched the International Thoracic Oncology Nurses Forum, which was developed to provide an international voice for lung cancer specific nurses. We quickly identified that we shouldn't be really using the term lung cancer specific or specialist nurses, because there's so many areas around the world that don't have the facilities to be able to have one nurse that specialises in lung cancer. So we're just calling on oncology nurses, palliative care nurses, research nurses who have a special interest in lung cancer, and we're advocating that nurses around the world should at least know somebody who specialises in lung cancer. It's the biggest killer. It's killing the most people in the world. We have breast care nurses who, have come into worth amazingly, that every patient who's diagnosed with breast cancer in Australia is automatically introduced to a breast care nurse. And that nurse then becomes, most of the patients have that nurse's mobile number, and they can call them at any time to ask them about their diagnosis, about their treatments, about any side effects they're having. And we feel that a lung cancer person should have that access as well. And they should have access to, medical oncologists, they have access to radiation, who have interest in lung cancer, and we feel that they should have that in nursing as well. And it's also about research. It's about proving the worth of the nurse and making sure that we can prove that they are a great asset to the MDT team. A few health professionals feel that nursing isn't an integral part to the MDT, but we feel that it truly is, and that most patients find that they can actually talk more openly and have less guilt talking to their nurses. In the Lancet that was released this month, which had an article in there which was adapted from the UK National Audit, it showed that 64.8% of patients with lung cancer or meso who were seen by cancer nurse coordinators, and in the UK they are lung cancer specific, were given active treatment at the right time, as opposed to 30.4% of patients who didn't receive any treatment at all, and those patients had no access to lung cancer nurse coordinators. So I think a very important part of the International Nurses Forum that we've just launched is to enter into some global research to prove the worth of nurses in MDT, and also prove the worth of how that nurse is actually impacting in the role of patients, better outcomes for their quality of life, better outcomes for their consumers and their families, the carers, and everyone alike.
When I first mentioned research, you came back with, you mean the lack of research?
Well, yeah, and there is research happening, nurse-led research around the world. It's very sporadic. It's mostly about symptom management, and it's mostly about nurse-led follow-up in the UK, because that's a big area. UK nursing or lung cancer nursing is leading the way. I don't think in the US there are any lung cancer specific nurses. There's probably oncology nurses or PAs who have a focus on lung cancer, but I don't think there's any specific ones. For an example between the UK and Australia, in the UK, the National Lung Cancer Nurses Forum, to be a member of that, you have to spend a majority of 50% of your time as being a lung cancer specific nurse. They've got nearly 300 members, which means they are lung cancer specific nurses. And they're the people who just choose to be a member. So there's lots who probably aren't even a member. In Australia, for example, we have about 15 nurses who specialise in lung cancer nursing. So in Australia, we're advocating that every patient who's diagnosed with lung cancer should have access to either a lung cancer specific nurse or at least a nurse who has a special interest in lung cancer. And the forum that we've established is to link people in Chile or in India who are nurses who are involved in lung cancer but want to actually reach out to their colleagues for mentoring, for research, for further education and become a global voice.
It would seem that there'd be a natural collaborative opportunity between the advocacy community and the nurses, and I'm wondering, how do you need or how can the advocate groups best engage with the nurses?
Sure. So I mean, I work for the Australian Lung Foundation, so we are an advocacy group. And with myself working with the Australian Nursing Forum, that's where the concept and the idea and linking with the UK nurses, that's where the idea came up with that we need a global voice. So the advocacies are one, supporting the nurses and giving them the ability to be able to come and network, because they're also busy in their own roles, they're also busy in their own lives and their own jobs, that they haven't got the abilities or they haven't got the internal structures like we do, that they could get this up and off the ground. So that's where we can help. We also help by a referral pathway. So we have a referral pathway for nurses, so we can refer them internally, but we can also refer patients. We get calls at the Lung Foundation from patients who are newly diagnosed, who are in regional areas, who are being sent into the cities for treatment, and they don't know a soul. They don't know who's around, they don't know where they should go, and we can actually link them directly with nurses.
Glenda, I've got a question. Australia's got quite an experience about having lung cancer nurses, and England as well, Great Britain. Are there any comparison about the work that other types of cancer nurses do, and what influence does the stigmata have on the work of a lung cancer nurse compared to other nurses with other cancer types?
We know that lung cancer nurses or nurses who see a lot of lung cancer patients have a massive burnout. They don't stay in the role for very long, and that's something that we're going to try and fix by coming up with some courses more about self-care, to be able to support the nurse in the role of being a lung cancer nurse. So it's the stigma is quite big, and I think that's where this research, that 65%, almost 65% of patients who see a nurse get treatment. And I think by being able to talk to a nurse is alleviating that stigma or that self-belief or self-doubt that they deserve what they've got, and let's just go home and die. Let's get active treatment, let's work through the process. And the nurse is usually there at time of consultation and talks the patient through exactly what's ahead of them, what they can expect, what they cannot expect. And I think involving the nurse early in the process of diagnosis is actually helping reduce the self-stigma, not so much about the stigma out in the community, but the self-stigma associated to a person who's diagnosed with lung cancer.
What do we do to really help ensure that lung cancer patients are getting the multidisciplinary clinical approach that's really imperative to this disease? Regina.
I'm smiling because I think we struggle with that greatly. It's something that we see, that patients who are treated in the community often are not treated appropriately. And I'm not doing that to rail against community oncologists by any means. We hear those stories. And I think that's something that we need to work very hard on, is to ensure that patients do have access to multimodality care, because it's true, many patients will need multiple types of care, including nursing.